Hello, this is Dr. Grant Cooper from Princeton Spine and Joint Center. A few days ago, I was explaining degenerative joint disease to a patient in my office. And when I was done, the patient said to me that he thought I should make what I had just told him into a YouTube video because he said that for the first time, he understood why his right knee was hurting him and not his left knee, even though an x-ray had shown that both of his knees were filled with arthritis. Now, I appreciated what the patient told me, and in truth, I've heard that from patients a lot about this topic in particular, that it can be very confusing. So I thought it was worth taking my patient's advice and making a video on this topic. So it is in that spirit that today's video is going to talk about degenerative joint disease, with some special points made about knee, hip, and spinal osteoarthritis, otherwise known as degenerative joint disease in particular. Okay, so first, what is degenerative joint disease? Well, degenerative joint disease is another way of saying osteoarthritis or wear and tear of the synovial joints in the body. The two most common joints that are affected by degenerative joint disease are the knees, which are the most common, and the hips, which are the second most common. The hands and spine are also very common joints to develop osteoarthritis, again, otherwise known as degenerative joint disease as well. And now with that said, any synovial joint can develop degenerative joint disease, and this would include the shoulders, the elbows, the ankles, toes, etc. Now in this video, I'd like to explain exactly what degenerative joint disease really is and how it affects you. I'd like to put to rest some common misconceptions about degenerative joint disease, and then importantly, to discuss how to treat it in the present and how to prevent it from bothering you into the future. Okay, let's dive in. Degenerative joint disease is fundamentally a problem of the cartilage in a joint. Now specifically, degenerative joint disease is a problem of a loss of that cartilage. So what is cartilage? Well, all synovial joints have cartilage in them. The best way to think about what cartilage is that it's like a sponge. When your joint is at rest, the cartilage holds onto your joint's natural fluid like a sponge holds onto water. When you move your joint around, or if you put it under a load, such as simply standing up if it's a weight-bearing joint, like with the hip or the knee, because now gravity is pushing your weight through the joints, well then the cartilage in that joint is squeezed. And the joint fluid that was in the cartilage is now pushed out of the cartilage, just like a sponge being squeezed pushes the water out of the sponge, and that fluid then bathes and nourishes the whole joint. When the joint returns to rest, the fluid then re-enters the cartilage and it's stored there. In degenerative joint disease, and again, synonyms for degenerative joint disease would include osteoarthritis or wear and tear of a joint, the cartilage in the joint breaks down and is lost. As you lose the cartilage in your joint, you lose the ability to hold onto your joint fluid in your joint. And once you start losing the joint fluid, the joint can't be lubricated, it can't be nourished in the same way that it needs to be, and this starts a cascade of degenerative changes that affects the whole joint and the joint surrounding soft tissues. So for example, the subchondral bone becomes inflamed and it compensates by growing more bone. But this new bone isn't made as well as the original bone structure. Bone spurs can then begin to develop, as can cysts within the bone. And additionally, the soft tissue that's lining the joint becomes exposed to inflammatory proteins that are released, and increased pressures that used to go through the healthy bone is now redistributed throughout the joint and throughout the joint surrounding soft tissue, which can then also cause further breakdown and potentially inflammation. The joint responds to these stresses by putting more and more strain on the surrounding muscles, tendons, and ligaments, as well as further increasing subchondral bone turnover that unfortunately just exacerbates the problem. Now, here's a really interesting and critical thing to know about degenerative joint disease, and that is that everyone gets it. Everyone. That is, if you live long enough, you're guaranteed to at least develop radiographic evidence of degenerative joint disease at some point. So that is to say that if you took a picture inside your body, you're going to see degenerative joint disease. But the kicker is that just because you'll develop degenerative joint disease or arthritis, this doesn't necessarily mean that you'll ever develop pain in your joints. All that it means is that you're guaranteed to eventually see on a picture arthritis or wear and tear in the joint if you happen to take a picture of the joint, such as with an x-ray or an MRI. Now, studies on this vary, but most studies agree that by the time someone is 60 years of age, at least 60% of people will show knee osteoarthritis on an x-ray. And virtually everyone by 60 will have some facet joint arthritis visible in the spine. By the time someone is 80, it would be virtually unheard of to not see at least some osteoarthritis in the weight-bearing joints of the knees, hips, and spine. Now, indeed, if I had an 80-year-old who came in to see me and they had an x-ray of their hip or spine and there was no arthritis at all, it would be an absolute marvel. In fact, in many, many thousands of patients encounters, my colleagues and I can't recall ever seeing that, and we wouldn't expect to. But the take-home point, and this is the really important part, is that most people with radiographic evidence of degenerative joint disease don't necessarily have any symptoms. So just because you might have an x-ray or MRI that might show osteoarthritis in the hip, knee, shoulder, spine, hand, or any other joint, it doesn't mean that that joint is necessarily causing you any pain or ever will cause you any pain. That's important enough that I think it bears repeating. X-ray evidence of degenerative joint disease, even severe degenerative joint disease on an x-ray, doesn't mean that the joint in question will necessarily be painful. Now, this isn't at all to say that degenerative joint disease can't or doesn't cause debilitating pain in some people. To be crystal clear, degenerative joint disease clearly does cause extreme, terrible pain in some people. But what I'm trying to convey to you is that the mere presence of degenerative joint disease on an x-ray doesn't mean that it will necessarily ever cause any symptoms from those degenerative changes. Indeed, getting too hung up on x-ray findings can sometimes lead both the patient and dare I say it, and a misguided doctor astray from the true diagnosis. I've seen this many times, way too many times over the years. There's one patient that comes to mind who illustrates this phenomenon, unfortunately, perfectly. I saw him a few years ago. He was about 65 years old at the time, and he had obvious severe knee pain. So this fellow had seen an orthopedic surgeon in Queens, New York, and the orthopedist had told him that his knee pain was in fact coming from his hip, because on his x-rays, his hip was severely arthritic and his knee was only mildly arthritic. So now it is true that hips can refer pain to the knee. It's not the most common thing. And this is certainly not the way to diagnose it based purely on the x-rays. But nevertheless, this patient faithfully believed what his orthopedist had told him, and he had a hip replacement already scheduled. But he came all the way, about 2 hours from where he lived, to Princeton to see me for a second opinion because someone who he trusted told him that his story just didn't sound right. And indeed, it certainly didn't. So anyway, there he was in my office. And now, sure enough, it was clear as day to me that his pain was coming from his knee, despite all of the x-ray findings of his knees and his hips. And I was able to prove this to everyone, to him, to me, to his other doctors, by injecting his knee under ultrasound guidance with lidocaine and steroid and taking away all of his inflammation and pain. Now this, along with physical therapy, not only put him on the road to a full recovery, but importantly, it confirmed the diagnosis and it saved him from a big, unnecessary, and ultimately what would have been a very harmful surgery. This is just a great example of why x-rays are often helpful to get, but they're really only one part of the clinical picture. And as the saying goes, treat a person and not just the x-ray. Now consider another data point. It's extremely common that someone with right knee osteoarthritis who has a lot of pain in the right knee may get x-rays of both knees for comparison, and the left knee is often just as arthritic as the right knee, but there's no pain in the left knee. Or consider another data point. Often a patient presents to his or her doctor's office with, let's say, 6 months of knee pain. The patient says that nothing happened, but that one day their knee just started to hurt. So the patient gets an x-ray and the x-ray shows moderate osteoarthritis in the knee. Well, when that happens, when do you think that knee osteoarthritis developed? It takes years for osteoarthritis to develop. So if you had gotten an x-ray in that same person's knee a year or 2 years earlier, it probably would have looked morphologically more or less the same on the x-ray. The difference is that a year or two ago, the person had the arthritic knee on the x-ray, but didn't have any symptoms. Okay, so what's going on here? Because to be clear, it's not intuitive. Why do some people with degenerative joint disease have terrible, debilitating joint pain, whereas other people with the same morphologic appearance on an x-ray have no symptoms whatsoever? And then, of course, many, if not most people, are in between those two extremes and might have degenerative joint disease, and they'll have some moderate degree of symptoms. Now, further, why do some people with severe degenerative joint disease have mild symptoms, while other people with mild degenerative joint disease have severe symptoms? And the reason for these discrepancies, as it turns out, because again, it's not intuitive, and this really is the most important takeaway point from all of this, is that it's not the degenerative joint disease itself that causes the pain. The pain comes if and only if, except in rare exceptions, if the body responds to the degenerative joint disease with inflammation. And it's that inflammatory reaction that either causes pain or doesn't. And because of this, treating people with symptomatic hip or knee arthritis or other forms of degenerative joint disease is really not about making the arthritis go away per se, but rather it's about eliminating the inflammation and changing the underlying biomechanics in order to unload or take the pressure off of the offending joint so that the inflammation doesn't return in the future. And similarly, the best way to prevent symptoms from ever coming in the first place is to get your muscles to adequately support your joints so that they aren't overloaded and then the inflammation doesn't occur in the first place. Without that inflammatory response, there won't be pain, even if there's significant osteoarthritis or degenerative joint disease. Now let's consider the hip and knee in particular for a moment. When you take a step with your foot, right, there's a force vector that comes up through your foot and then gets transmitted into your ankle, your lower leg, your knee, thigh, hip, and then into your pelvis and spine up through your head. If your muscles contract, then they can take and absorb the pressure from that force vector. Now, on the other hand, if your muscles don't contract in an optimal way, well, that force is still going to come up one way or the other through your body. The force doesn't care. And if the muscles don't take up the slack, then that force is going to go through your joints. And your joints, they're stuck. They can't get out of the way. The joints are the last line of defense, and they'll end up taking and absorbing that force if the muscles don't. So let's stay with the knee for a moment. To prevent knee pain, we want to stretch and strengthen the muscles around the knee. Specifically for the knee, we'd like to strengthen the quadriceps and the hamstrings in particular, as well as strengthening the dorsiflexors of the ankle. And we want to make sure that the iliotibial band, quadriceps, hip flexors, hamstrings, and calf muscles are all nice and limber. Now, further afield, you want to also think about your gait, that is, how you walk, and make sure that your movements are as optimal as possible. If you're walking with a limp or with tight muscles that pull you to a side, this is going to put more stress on your joints as well. Making yourself overall more stable is also very helpful. And this will mean, among other things, making sure your hip abductors and your core are nice and strong to keep yourself stable in your gait and in your other movements. Now, with all that said, if you only had one exercise to do to help prevent knee osteoarthritis, for most people, I would focus on strengthening your quadriceps. But hopefully, you can do a more complete preventative workout than just doing, one exercise. Okay, let's take the situation of symptomatic hip or knee osteoarthritis. One way to address this is to go to physical therapy and work on stretching and strengthening the appropriate muscle groups. You could also check out our videos on the best exercises for hip pain and knee pain. But if the symptoms were to persist, or if the symptoms were so severe that you really can't even engage with the exercises, then sometimes you need to take a fire hose and just put out the fire. Now, in the hip and the knee, there are two common injections that are used as the fire hose. The injection that most people are familiar with is a steroid injection. Some people call this a cortisone shot. Now, in fact, no one actually injects cortisone per se, but we use different steroid derivatives. So anyway, a steroid is a strong anti-inflammatory medication. The advantage of a steroid injection is that it generally works really well and pretty fast. The steroids, when they're injected, aren't active, and the body has to metabolize the medication to make it active, and that generally takes about a day or two or three for the medication to take effect. When the steroid injection does its job and works and reduces the inflammation, the pain gets a lot better or goes away completely. Now, when this happens, it's important to recognize that the pain hasn't been masked by the steroid. That is, the steroid injection itself is not a Band-Aid. The steroid injection has addressed the inflammation. However, what the steroid injection has not done is to change or address in any way the biomechanics that led to the inflammation and therefore the pain in the first place. So indeed, if all you were to do were steroid injections, the steroid injections tend to last for only about 3 months. And then the inflammation and therefore the pain tends to come back. So if you do use a steroid injection, it's very important to think of it as only step 1 of a treatment plan. The steroid injection, in effect, becomes a window of opportunity during which the inflammation is removed, and this allows you to focus on learning and doing the targeted exercises in order to change the underlying biomechanics so that the inflammation doesn't return in, say, 3 months. Now, the main disadvantage of a steroid injection into a joint is that steroids don't belong in a joint, and repeated steroid injections can potentially damage the cartilage in a joint. So you want to be judicious in your use of steroids in joints in general. The other common type of injection for hip and knee osteoarthritis is something called viscosupplementation. Now, viscosupplementation is also referred to as hyaluronic acid injections, and these are generally a series of anywhere from 1 to 5 injections, usually once a week, depending on the commercial product that's used. The more common commercial products are Euflexa, Synvisc, Hyalgan, Orthovisc. There are several others that are now available on the market. But basically, all of these products work in the same basic way, in that they're designed to replace the joint fluid in your joint. Recall that in degenerative joint disease, the underlying problem is that you lose the cartilage in the joint. Remember, the cartilage is what holds onto the joint fluid, and as you lose the cartilage, you lose your joint fluid. So unfortunately, we can't replace the cartilage, not yet, but we can replace the joint fluid. And one of the positive things about viscosupplementation is that it's basically a net benefit for the joint. That is, by putting in the viscosupplementation, you're nourishing the joint and providing it with lubrication. It's a natural solution in that you're replacing the fluid that is supposed to be in the joint anyway. Another positive aspect of viscosupplementation is that the effects of the fluid that you're putting in, if you didn't do anything else, generally last for about 6 months. Now, of course, ideally, you should think of viscosupplementation similar to steroids in that you're also offering a window of opportunity during which the inflammation and therefore the pain is reduced, the joint is nourished, so you can now focus on learning and performing your exercises in order to change the biomechanics so that 6 months later, you don't need to repeat the injection series. A quick story here. I took care of an older doctor one time who hated doing exercise. I mean, he hated doing exercise. He had significant knee pain from knee osteoarthritis in both of his knees. And I would give him the viscosupplementation injections. And for 6 months, he would have virtually no knee pain or discomfort in either of his knees. But then the pain would return, and I would plead with him to do his knee exercises. But he just wouldn't do it. So for a few years, every 6 months, I would do a series of 3 injections, and off he would go to do his rounds in the hospital with no knee pain. Then 6 months later, like clockwork, another 3 shots of joint fluid, like an oil change. Finally, I suggested to him that instead of a full exercise program, which he clearly wouldn't do, he should just stand up and sit down repeatedly while he was watching television at home, because he did like to watch television at night. So while he watched his favorite TV shows, my advice was to just stand up, sit down, until he was too tired to continue to do it, and then rest, and then do it again. And in this way, he would strengthen his quadriceps, and he didn't have to think of it as, exercise. So for whatever reason, he liked that idea, and he did it. And the viscosupplementation injections, they started to last for about 15 months instead of 6. That was a great example of how even a little tweaking of the biomechanics around the knee, or around any affected joint for that matter, can go a long way. Now, I think, of course, if he had done a more complete exercise routine, then it would have lasted even longer. But you take what you can get and you work within someone's lifestyle. Now, the main disadvantage to the viscosupplementation injections is that they generally don't work right away. They can take anywhere from a few days to several weeks to kick in. So if someone's in severe pain, starting an injection series that might not offer pain relief for 4 weeks might seem daunting, and that needs to be taken into consideration when deciding how to treat an individual patient's pain. So sometimes you might start with a quicker acting injection, such as a steroid injection, if the pain is severe. But all of this really depends on a lot of factors that you would go over with your doctor. Viscosupplementation is most commonly used with the hips and the knees, but you can also use it for shoulder and ankle osteoarthritis, and it tends to work more or less just as well. Now, with smaller joints, like the facet joints in the spine or in the big toe or the thumb, the results are much less consistent, but some doctors still do offer it as a potential treatment option. Now, there's also a plethora of other non-surgical options for degenerative joint disease. Some doctors inject a liquid non-steroidal anti-inflammatory medication called Toradol. You can think of it as like a liquid Advil. It's actually liquid diclofenac, and the advantage of this approach is that it's a pretty good anti-inflammatory medication. It works quickly, and it doesn't have the potential deleterious effects of steroids in the joint. The main disadvantage is that it doesn't work as well as steroids for most people, but again, it's definitely an option that can be considered. Now, newer injection options include regenerative medicine techniques. The most common regenerative medicine injection for hip and knee osteoarthritis is something called PRP, and PRP is platelet-rich plasma. In PRP, you aspirate a person's blood, and then you use a special centrifuge to isolate the person's platelet growth factors, and these growth factors are then injected back into the inflamed joint. Now, once they're in the joint, they're intended to attract the body's natural healing mechanisms to the inflamed joint. PRP is becoming more and more popular for degenerative joint disease, but it's still not the standard of care, and it's not covered by insurance, so cost can be a real issue. There are lots of other regenerative medicine techniques. They're all designed to basically work in the same manner of helping the body to heal itself. Now, some of these include prolotherapy, which is basically sugar water, amniotic fluid, mesenchymal stem cells from the patient's own bone marrow, are some of the other regenerative techniques that are all showing promise, but none of them are yet the standard of care, and all of them aren't covered by insurance. So again, cost unfortunately becomes a factor. Now, when hip or knee pain is not responding to good conservative care, and when the symptoms are debilitating, then surgery can be an excellent option. Now, make no mistake, as common as hip and knee joint replacements have become, they're still big surgeries. However, for someone with severe pain, where the pain is really limiting their quality of life, joint replacements can be a life-changing surgery. And the surgical techniques, not to mention the anesthesia during the surgery, are getting much better all the time. I hope you found this video useful. Please remember to press the like button if you found the video useful. And of course, please subscribe to our channel if you haven't already for lots of videos on different musculoskeletal topics, some longer like this one, and some much, much shorter. And also we have lots of videos on the best exercises for different spine and joint issues. So please be sure to check all of that out. As always, I'd love to hear your comments, suggestions for future topics, as well as any questions. Thank you very much.